First of all, I just want to say, of course, it's an honor and a pleasure to be here. I've been in Israel now for a week, and it's been a fantastic week. Been hosted very graciously, met some incredible people, learned about some really progressive programs. I've really been inspired by being here this week, and I think this discussion is part of a possible change to a better way of helping each other. So I think I've been really inspired by this week. So thank you, and there's many people to thank: Tauber Foundation, Sylvia, Gotti and Ruthie, ISPRA, and everybody I've been with has just been so welcoming. I think I wish the talk you just heard, and maybe the talk you're going to hear now, helps frame the issue so well. I thought that was brilliant in terms of framing the issues. And one of the things you're now going to hear is a discussion of a lot of the same issues. But one of the questions, which really is a question for society and for professionals and for people taking the drugs with shared decision-making, is even how to interpret the evidence. And then once you confront this evidence, of how you can work it into protocols. So you notice that Dr. Goff talked about a paper he wrote sort of addressing this issue. A lot of the studies they looked at were studies that you're going to hear about now. So one of the things you can see is maybe there is a literature for you to review and start thinking about while you interpret it, okay? Because people do interpret things. And one of the things that was interesting for me after that paper came out, I basically went over the differences in interpretation between this group and frankly, how I see some of this. I'm an outsider, not a psychiatrist. I'm not even a provider. I came at this as a journalist, though very much schooled, and this was part of when I was at Harvard Medical School, as the director of publications, in the importance of evidence-based medicine. So when I came to this whole topic, the one of the issue today, how do antipsychotics affect long-term outcomes, it was through this lens of understanding an evidence base, okay? Now, you'll see that Dr. Goff said there's clear evidence about that in trials over the short term, you take people coming in an emergency room, half randomized to placebo, half randomized to drug. The drug group with great regularity has a greater abatement of symptoms, okay? And that is the evidence for short-term efficacy. I will say, though, there's a hole in that short-term literature, is that here we are in 2016, there are not any really good evidence from placebo-controlled trials of the efficacy of neuroleptics in medication-naive patients. In other words, patients never exposed. Those trials are still waiting to be done, and I think it's something that you identified in your study. In terms of long-term use, again, you see studies in which you take patients that are stabilized on the medications. Okay, so you are actually doing these studies in a subset of patients, the good responders, because you basically have to be stabilized, and then half are withdrawn from the drug, half remained on the drug, and those withdrawn do relapse at a higher rate. Okay, and that is usually the evidence cited for the long-term use. The drugs lower the risk that the disease returns, okay? They lower the risk of relapse. I think there is a third part of the evidence base that in some ways is the compelling one. So you're a clinician, and what do you see? Someone comes to you with psychosis, and you give them a drug. They often get better after 8 weeks. They go home, they don't like the drug, they throw away the drug, and they come back to your hospital. So what do you see? You see drugs that work, and you see when people quit taking the drug, they come back to you. And I think actually, in terms of change, that clinical experience may be the most compelling evidence in a way. But now let's keep going. And I hope what you do here is you sort of follow me through a thinking process. You don't have to agree with me, but sort of to see that maybe what we need is a real focus on this evidence and a focus on interpreting it. The evidence base, I think, has some obvious limitations. If you take those relapse studies, they don't tell you how people are functioning, right? It doesn't tell you if people are working, it doesn't tell you if people are in school, it doesn't tell you about their subjective lives, that sort of thing. It also really doesn't tell you what is happening to patients over the course of 2 years, 5 years, 10 years. What it's telling you is that once a person is stabilized on the drug, there's a higher risk of relapse if you come off. That's what that's telling you, okay? Now, the second part is that relapse rate, and Dr. Goff spoke about this briefly. Is it a return of the disease? Or is it higher than it might normally would be because you've been on the drug, your brain has compensated to the presence of the drug, you get this increase in D2 receptors, and does that make you more vulnerable to relapse? So are you really seeing a return of the disease, in the language of the medical model, or are you seeing an inflated relapse rate because the brain has become used to the drug? That's one of the questions to address in terms of the merits of the literature. Now, the third part is this. Do clinicians today have any experience with the long-term course of unmedicated psychosis? They don't, right? Because you medicate people, and that's what you see. You see the course of psychosis as mediated by the use of these medications. So we don't really know what is the long-term course, and I think sure it's going to be a heterogeneous course. If you have 100 people with the first episode, and you didn't put them on antipsychotics, what sort of grouping of outcomes would you see over the course of 2, 5, and 10 years? And we're going to see if the literature provides any insight into that, okay? But the clinician's perception it's limited, because in terms of what we call the natural course of the disorder, we do not see it today. So I'm a journalist. I'm trying to follow the evidence base. It's pretty easy to see that there's these sort of holes in the evidence base. Then the next thing you want to do, from my point of view, when I first took this on, was to say, well, can people in the field, the experts in the field, can they point me to other types of studies that show that these drugs are effective in improving long-term outcomes? And by the way, one of the principles of evidence-based medicine is that there's a responsibility on those doing the treatment to have the evidence that they are in fact helpful. That's one of the basic principles. And one of the principles, by the way, of evidence-based medicine, why you need it, is that the history of medicine shows us that there is a potential or a capacity for medicine to be deluded about the merits of their therapies. So that's one of the ideas here, is you can't rely on clinicians' perception necessarily for assessing the merits. Anyway, I did that. I looked to see, can someone point me to other types of evidence that show this type of care, which is so common, which is really the cornerstone of care, at least in the United States, for those with psychotic disorders, that it's improving their lives over the long term. And in 2002, Emmanuel Stipp, he's a Canadian psychiatrist, he writes this: after 50 years of neuroleptics, which is another name for antipsychotics, are we able to answer the following simple question? Are these drugs effective in treating schizophrenia? And then he says, there is no compelling evidence on the matter when long-term is considered. Okay, so again, follow me here. I'm saying, can the profession show me where they have the evidence that this is improving long-term? And you say, they don't have it. To me, this is a green light, that this is a worthwhile investigation to see, as we go through the scientific literature, if maybe we can get some, at least hints to this, answering this question. And then he says this. I love this line. If we wish to base psychiatry on evidence-based medicine, we run a genuine risk in taking a close look at what has long been considered fact. And in essence, that's what you're doing here today. You're taking the risk of maybe having understandings questioned. Now, one of the first things I wanted to do was to see what sort of outcomes were being reported in the decade before the first antipsychotic arrived in asylum medicine. So chlorpromazine, which you call, I'm going to mispronounce it, but largactil in Europe, was introduced in asylum medicine in 1955. The following year, or a few years later, the NIMH convened a meeting to say, how are we going to know if these drugs are effective? And one of the things they said is, well, we have to look at the outcomes we're getting today and see, before the drugs came, and see now if we can improve on that. And here's your first surprise as you go back through the literature. The prevailing conception, the prevailing understanding is that before the antipsychotics, people didn't get well. They didn't leave the hospital, and that's because, of course, you had a buildup of chronic patients. But here's where the studies at this NIMH conference that they put forward to say what sort of outcomes are we getting today, and there's a surprise. You will find that within 12 to 18 months, roughly 65% of the first episode patients would be discharged, and then even more important, if you have 100 first episode patients and you come back and look at them 3 to 5 years later, from 1945 to 1955, what percentage were living independently in the community? And you'll see, one it was 73%, the other was 70%. So we have this in our memory, a baseline understanding that no one got better before the antipsychotics. It's just not true. So from this decade, you'll see about 2/3 would be discharged and about 2/3 would be living independently in the community, and this is before the arrival of antipsychotic medications. Now in England, where they were diagnosing schizophrenia more narrowly at this time, this is before the arrival of antipsychotics, 33% would enjoy a complete recovery and another 20% a social recovery, which meant they could live independently in the community. Remember this too. When we talk about whether drugs improve or harm long-term outcomes, in order to improve on long-term outcomes, you have to improve on the natural capacity to recover. Okay? So you might have a number of people doing well on your therapy, but you're not improving on it as a therapy unless you're improving on the natural capacity to recover. So next thing we can look at, and I'm sort of going a little fast here, is then there was a study done, commissioned by the NIMH, that wanted to say is, okay, now we're using these medications. Are we seeing improved outcomes? Let's do a retrospective study. And Sanford Bachhoven at the Boston Psychopathic Hospital had outcome data for a group of patients, first episode patients, treated with psychosocial care in 1947, but no drugs, of course, with another group in 1967 treated with psychosocial care and drugs, and what did he find? Well, first he found that the relapse rate in 67 was slightly higher, but more important was the functioning. In the pre-antipsychotic era, 76% were successfully living in the community at the end of 5 years. The 67 cohort was much less likely to be working. They were much more socially dependent on welfare, et cetera, than the 1947 cohort. So what did Sanford Bachhoven conclude from this comparison? I'll just let you read it. I think it's important that you read the researcher's own words. And you see what he's saying here is if we're interested in long-term functional outcome, we may need to rethink this, okay, the use of the medications. But this is a comparison of what outcomes they were seeing before the drugs and now in the decade after. Now, because there were some concerns about the long-term effects of antipsychotics and their adverse effects, the National Institute of Mental Health, and that's the agency in the United States that funds research, okay, that funds psychiatric research. And in the 1970s, they're going to fund 3 studies that are going to compare conventional care with experimental forms of care over longer periods of time. One has a 1-year length, one has a 2 years, one has a 3 years. And in this experimental arm, you're either going to not use drugs or it's going to be a selective use model, and we're going to start to see some grouping of outcomes depending on whether people were medicated or unmedicated. Now, this was a randomized study. It was by Maurice Rappaport at the University of California, San Francisco. People come into the hospital, and they're either randomized to drug or they're randomized to placebo, and then they're discharged, and he's going to follow them for 3 years. And now once they're discharged, of course, though it becomes a naturalistic study. Someone randomized to drug can stay off, randomized to placebo can stay off. Someone randomized to antipsychotic may go off or may go on. And so he ends up with 4 groups. And here's the data as he reports it. From the 41 patients that he gathered data for that were randomized to the no meds placebo group, 24 of the 41 never went on meds in the 3 years, and you'll see here 2 things. they had by far the least severity of illness at the end of 3 years, and they had the lowest rehospitalization rate, okay? All right, now this is a group that was never exposed to the drugs. Which group had the highest rehospitalization rate? It was antipsychotic and on. In other words, that took the drugs for 3 years. Now, I know as we go through, there can be all sorts of quibbles about this, but you see a dramatic difference, and maybe you're seeing here that many people with not being exposed to the medication, if they can get through this episode, they can have a good long-term outcome. The second one, okay, just read this too. I'm going to have to get going here. But what you'll see is Maurice Rappaport says this. We may need to rethink this if one is interested in long-term clinical improvement. And so what he's saying is here, many unmedicated while in hospital patients showed greater long-term improvement, less pathology of follow-up, fewer rehospitalizations, and better overall functioning than patients who were given drug in the hospital. Now, Loren Mosher, he was the head of schizophrenia studies at this time, meaning he's the head schizophrenia doctor in the United States. He ran a very famous study called the Soteria Project. Some of you will be familiar with that name here. And it wasn't perfectly randomized because of some insurance things, but basically here was the design of the study. Early schizophrenia spectrum patients that come to a hospital, they either get conventional care in the hospital with drugs, or they're randomized to this Victorian house, which is staffed by people that can be with others. And in this experimental arm, they weren't put on neuroleptics right away. Benzodiazepines were used to restore sleep-wake cycles. And now, if someone weren't getting better after a period of time, then they were put on antipsychotics. So it's a delayed-use model. The project actually ran for 12 years, and here were his results. First of all, at 6 weeks, the diminishment in psychotic symptoms was the same in both groups. In other words, this experimental form of care was just as effective over the short term, all right? But at the end of 2 years, the patients in this experimental arm had lower psychopathology scores, fewer readmissions, better global adjustments, and now we see a selective use model. He said in terms of antipsychotic use, 42% had never been exposed to drugs, 39% had used them temporarily, and 19% had used them regularly throughout the 2-year follow-up, as if maybe there's 3 groups of patients. One that can get through an early episode without going on the drug, another one that needs the drug temporarily, and a third one continually. So what does he say? He says, contrary to popular views, minimal use of antipsychotic medications combined with specially designed psychosocial intervention for patients is not harmful, but appears to be advantageous. What I hope you see here is that I was following a mainstream line of research, and I was following what the conclusions were by the researchers themselves about rethinking the use of these medications. Now, and he says, we think the balance of risks and benefits associated with the common practice of medicating nearly all early episodes should be re-examined. There was a third such study by William Carpenter at the NIMH. He's a very famous schizophrenia researcher in this study. The study's complicated, but one part of the study compared psychotherapy plus drug with psychotherapy without drug, had 49 patients in those 2 comparisons. And at the end of 1 year, the group that wasn't on drug had a little bit lower relapse rate, but also had better functioning and less depression. And now William Carpenter raises the very question that would basically, from the first talk you heard, still hovers over the field. Relapse studies. There is no question that once patients are placed on medication, they are less vulnerable to relapse if maintained on the drugs. That's the relapse studies. But what if these patients had never been treated with drugs to begin with? We raise the possibility that this medication may make some schizophrenic patients more vulnerable to future relapse than would be the case in the normal course of the illness. So he's raising this very critical question that I would say to you is still present. Okay? And we're not talking about adverse effects here. We're talking on the target symptom of psychosis, the very thing the drug is supposed to do. Are you making people more biologically vulnerable to that target symptom, okay? Now, at that time, there was 2 research, they were just discovering the mechanism of action of antipsychotics, and 2 researchers from McGill University, Guy Chenard and Barry Jones said, we think we know what's happening. So what happens is this. How do antipsychotics work? Here's what happens. How do neurons communicate in the brain? You have a presynaptic neuron that releases a chemical messenger. Dopamine is a type of chemical messenger into the gap between neurons, which we call the synaptic cleft, and then that neuron, that molecule, the dopamine or serotonin or whatever the chemical messenger is, binds with receptors on the receiving neuron, which we call the postsynaptic one. That's how the neurons communicate, okay? So what does an antipsychotic do? An antipsychotic blocks the receptors, these dopamine receptors on the postsynaptic neuron, and they block a particular type of a receptor called the D2 receptor, and at a therapeutic dose, they block about 70% of them. So the drug is acting as a blockade of a dopamine transmission. So your brain, being this very neuroplastic organism with all sorts of feedback loops, now starts to say, we have to maintain a homeostatic equilibrium. We have to maintain these neuronal passageways, and they do it basically in two ways. At least for a time, there is an increase, it seems, of dopamine release from the presynaptic neurons. I do think the evidence is that then stops. But then, and you can see this, the postsynaptic neurons increase their density of receptors for dopamine, and the brain is now said to be supersensitive to dopamine, okay? And this is just a description of how the brain is changed by exposure to the drug. So think about this. Drug acts as a blockade. Your brain puts down, this compensatory adaptation. In essence, it's trying to accelerate or become more sensitive to dopamine, okay? This is your new homeostatic equilibrium. Now take away the drug when you do a relapse study. Is this a problem? That's the question. Is that a problem? And what they said, Guy Chenard, this is a problem. They said neuroleptics can produce a dopamine supersensitivity that leads to both dyskinetic, that's the motor problems, and psychotic symptoms. An implication is that the tendency towards psychotic relapse in a patient who has developed such a supersensitivity is determined by more than just the normal course of the illness. So they are saying at this time that the drugs induce a biological change that, at least in many patients, makes them more vulnerable to the very symptom you're trying to treat, okay? And what you can see here, in my opinion, is some brilliant science. It's illuminating a paradox. Clinicians aren't seeing this, right? But this is illuminating a possible paradox. Now, this is in the early 1980s. It's now 2017. Do we have other evidence that in some ways fits with this worry or contradicts it? And what I'm going to do now is very quickly is just go over the research I can find that at least helps us think about this problem. So cross-cultural studies. By the way, sorry, I do my slides in Keynote, and I had to put them now in PowerPoint, and they didn't exactly export all well. The World Health Organization in the 1970s and 1980s conducted two studies, one 2 years in length and one 5 years in length, that compared outcomes in 3 developing countries, India, Colombia, and Nigeria, with outcomes in the US, and I think it was 5 other, quote, developed countries. Now, after the first one, which was the 5-year study, they said, look, at the outcomes are better in the poor countries, in the developing countries. And after the first, and by the way, read this. This was actually the very finding that got me interested in this whole thing, in a deeper thing. They said, considerably better course and outcome. They concluded that, quote, being in a developed country was a strong predictor, if you're diagnosed with schizophrenia, of not attaining a complete remission. And to me, this was a sign of a failure. Why would be living in a rich country or a developed country with all its advanced medicine being a predictor of a poor outcome? Now, in the second study, one of the hypotheses after the first study was maybe the patients in the poor countries are more medication compliant. That's why they have the better outcomes, which is a valid hypothesis. If drugs are so essential, compliance should be associated with better outcomes. And here's what they found. In the developing countries, they were, at that time, this has changed since then, using the drugs acutely, but not chronically. So only 16% of the patients were maintained regularly on drugs, whereas in the US and other rich countries, it was the standard of care in 61%. Then they went back 15 to 20 years later. They looked at these same patients and they said the outcome differential held up for general clinical state, symptomatology, disability, and social functioning. In other words, in these cross-cultural studies, where in the earlier part they did not maintain people regularly on antipsychotics, and they came back 15 to 20 years later, that group was doing better, okay? Now, next is this question about the shrinkage of brain volumes. So, Nancy Andreasen is a very famous person in the United States. She was the longtime editor of the American Journal of Psychiatry. So, and she launches a big study in the 1990s, and she has a theory. The theory is that maybe schizophrenia is a neurodegenerative disease characterized by brain volume loss over time. And my point of emphasizing who she is, these are people who are researching this disorder within the sort of medical model, disease model paradigm, okay? So she reports that, indeed, that's what she's found. It's a progressive neurodevelopmental disorder characterized by progressive reduction in frontal white matter volume. You heard Dr. Goff talk about the hippocampus. The question is, where is the shrinkage happening? And one response I might have is, I don't think the hippocampus is a dopamine-driven area of the brain. And the question is it happening in dopamine-driven areas of the brain? So then, if you read her stuff closely, she reports that this brain shrinkage is associated with a worsening in negative symptoms, increased functional impairment, and after 5 years, cognitive decline. So her story is this. You're getting these brain morphological changes in an area of the brain, and as that happens, you're seeing this deterioration, okay? That's her description of a disease process. However, there was a study in monkeys, macaque monkeys, ordinary monkeys, and you either have one group that does not get antipsychotics, and the other group either gets Haldol or olanzapine at a dosage appropriate for their weights. You wait roughly 2 years, you sacrifice the brains, and what did this researcher find? That those monkeys on antipsychotic, their brains now weighed about 10% less. Okay? Now for me, there's a lot of different interpretations of this. For me, that was a pretty strong signal that it was the drug. Okay? That was me. But there's arguments against that. But then Andreasen went back to her own data, and here's what she said. The shrinkage was drug-related. Use of the old neuroleptics, the atypical antipsychotics, and clozapine, quote, were all associated with smaller brain tissue volumes, with decreases in both white and gray matter. The severity of illness and substance abuse had minimal or no effect on brain volumes. Now, I think there's still an open question of whether is this shrinkage entirely due to drug, or is it in fact you get some from the whatever the disorder process, and this just exacerbates that shrinkage. But either way, it's a negative because of this association with worse, functioning, etc. Anyway, real quickly, then I saw this. There's now been a 2012 review of 43 brain imaging studies of first episode psychosis, and that European researchers determined that a loss of gray matter volume was significantly more severe in medicated patients. So, first of all, if anyone is on, I'm sure there are people taking antipsychotics here. Whenever I come to this, I feel bad. I feel like, should I even be talking about this? Anybody here who is on medications should not take this as meaning any individual information whatsoever. And we do know that some people do well on the meds. Please do not use this as a treatment choice thought, but it is a thought for thinking about these drugs as a whole. Okay? And I think at the very least, what we've identified here today, this is a subject that perhaps needs more research and more thinking about, and the tying of these morphological changes to changes in symptoms, etc. Next. I got about 10, 15 minutes, something like that? Okay. You're going to get the rushed version of the rest of the literature. So, Martin Harrow, he's a psychologist at the University of Illinois, late 70s and beginning of 1980s. He began a long-term outcome study, and here's how their study was designed. They took 200 patients from 2 area hospitals. One was private and one was public. Everybody was treated conventionally in the hospital, no randomization. They're discharged, and now Martin is just going to follow them up at 2, 4.5, 7.5, 10, 15, and 20 years. At each follow-up, he's going to look at cognition, anxiety, psychotic symptoms, whether they're working, and whether they're using medications. You will see that his hypothesis is that those who take themselves off medication will do poorly long-term. What's nice about this study, half it's the first episode, another 21%, they've just had one previous, meeting the age of 23 years. In other words, he's following this course early on. Okay, and here's his results. These are psychotic symptoms just at the 10-year follow-up and the 15-year follow-up. You'll see it's, okay, this is at the end of 15 years, he has 64 schizophrenia patients and 81 with milder disorders still in the study. Started with 200, he still has 145. That's a really good, a low dropout rate. Of the 64 with schizophrenia off, I think there are 25 off at these basically 10 and 15-year follow-ups, off antipsychotics. What do you see? You see that the group on medication is much more likely to be actively psychotic. Now, one interpretation is this is consistent with the dopamine supersensitivity worry that it increases the chronicity of the disorder. That's one possible interpretation. Here, watch this real quickly. You see what's happening at year 2? Okay, at year 2, the people off medication are anxious. Both groups are. But look what happens between year 2 and 4.5. You see that the off medication group, it's not that they were well on meds, and then are well off meds and continued well off meds. They weren't doing well off meds at year 2, but you see this healing between year 2 and 4.5. In my opinion, this is the only place in the literature you start to see this longer term healing. This is cognitive function. It was better for the off med group at each follow-up. Work history, you'll see that the group that, this is really interesting. Here's what he's done is he's looked at this. He's looked at people who were off by year 2 and never went back on the drugs through the next 20 years. And the red group is a group that was medication compliant throughout. They never stopped taking their medication. And you see there is this dramatic difference in work. Whereas one group is going back to work, the other is not. This is long-term recovery rates. To be in recovery, you had to be asymptomatic, you had to be working or in school half-time, and you had to have some decent social function. Where is there the divergence in outcomes? When does it happen? Between year 2 and 4.5. Your relapse studies won't capture this. Okay, this is a healing that takes place later. Anyway, by the year 4.5 years, it's 40% versus basically 5%. It's 8 times higher. That stays through the 15 years for the off-med group. Now, he has a spectrum of outcomes. He has in recovery, so-so, universally poor. For the on-antipsychotic groups at the end of 15 years, it's 5% recovered, 46% fair, 49% uniformly poor. Off antipsychotics, it's 40% recovery, 44% fair, 16% uniformly poor. In other words, there's a shift towards chronicity across the spectrum of outcomes. You see that? So it's not just a lower recovery rate, it's a much more uniformly poor rate. And here's what he concluded from his own research. And you can read it. Now, this is the best long-term outcome study we've had, naturalistic, in the United States in the drug era. Now, it's right, we don't have a randomized study, and you know what? We're never going to have one. We're never going to have a randomized study that lasts 15, 20 years. So the question is, what can you draw from this? And I will tell you, one of the criticisms of Anatomy of an Epidemic, and what Dr. Goff and his colleagues did in this paper, were they're not very impressed with this data, okay, because of the naturalistic design. So that's one of the questions. Does it fit with the dopamine supersensitivity problem? Does it tell us anything about outcomes or not? One of the things, I'm sorry about this, when I did this to PowerPoint. In essence, Martin Harrow ends up with 4 groups. And one of the criticisms of Harrow is, and initially Harrow this says in himself, it's not that the drugs worsened outcomes, It's just that the better prognosis patients were the ones most likely to go off. So what we're just really seeing here is that there's a subset that's able to go off and do well. In the group with milder disorders, once again, it was the group off that did better. And he had 2 scales. Same use of scales, okay? But he had one for the schizophrenia patients, one for the milder disorders. So what I did is I put them together on one graphic. And here's what you see, the outcomes at the end of 15 years. The worst is schizophrenia on, okay? Next is milder disorders on. Then schizophrenia off, and best is other disorders off. So here's my question to you. Why does milder disorders on end up worse than schizophrenia off? Because schizophrenia is a prognosis to be that it's not a good prognosis. Now, in my interpretation, this is reason to think that the drugs on the whole are worsening the outcomes. Others will dispute that, okay? But you got to answer the question, why? Why did milder disorders on end up worse than schizophrenia off? And you can see what he writes. Is it undesirable? This is Lex Wondrich's study. You've already heard a lot about this. This is the relapse rate he was talking about. There was a greater relapse in the first 2 years on the drug-reduced discontinuation, higher in the drug, but by the end of 7 years, it was the same. By the way, as you heard, they managed that sort of return of symptoms. There weren't hospitalizations. This is the recovery rate at the end of 7 years. You'll see that that protocol choice of giving people a chance to taper produced higher recovery rates. Just one thing, I didn't conclude this. It becomes a naturalistic study after that moment of tapering, and you can also group the outcomes in both groups, the drug maintained and the drug tapered group, and the difference in outcomes between recovery rates becomes even more pronounced between the medicated and off-medicated or low dose and regular dose. So here's our director of the NIMH, and what I'm trying to say to you, and you sort of already heard this, is this question that you're being presented with today is percolating to the very top of American psychiatry. What does this say about the long-term use? This is our director of antipsychotics. Are they potentially harmful? Are they necessary for an individual's entire lifetime? We have to ask whether this is really a good form of care where we generally insist on long-term usage. Real quickly, this was a study done where the idea was we're going to get first episode patients, we're going to get them stabilized, and then we're going to do this study. We're going to give one group extra psychosocial care so they become medication compliant, because one of the thoughts is non-compliance is a real problem. The other group will get treatment as usual, okay, but not this extra psychosocial care. The expectation is this will lead to better medication compliance and better outcomes. It does work. There was better medication compliance, but however, they said, increases in medication adherence was associated with, quote, decreases in psychosocial functioning and increases in negative symptoms. So the compliance actually produced a negative result. Now, this is an early outcome study. You heard about duration of untreated psychosis. Couldn't agree more. Get it early. Get it early as possible, and we're going to conclude with the place that has the best outcomes in the Western world, and they have managed to help the people really early on. But you have to ask, what form of care? What is the early intervention? Is it psychosocial care plus drug, or whatever it might be? Early intervention is good, no question. Anyway, in this one, this was an early intervention study, 496 first episode. You can see at time of recruitment, they hadn't been on antipsychotics the last 12 weeks. At 10 years, there were 303 patients still in study. There were 121 who were non-compliant, okay? It's not that they were tapered, they just stopped. And now we have two groups, 121 non-compliant. What is that? Then that would be 182 who are basically compliant. No differences in the baseline of these two groups. And here's their recovery rates here's their outcomes at the end of 10 years. The non-compliant group was more likely to be in remission, meaning not having psychotic symptoms, and they were more likely to be employed. Now again, one of the things for me as a journalist is, it's not about one study. It's about a history of science evolving over time, and do you see the different studies fitting into a coherent story? That's the question for me. So from my perspective, when I see this again as the remission data, right, that the antipsychotics, if anything, are increasing the risk of psychotic symptoms over the long term. Then this study, there was a finished birth cohort study. What is happening in this study was this. 1966, they have a group of patients they're following for their health outcomes. They've identified people with schizophrenia. They look at how they're doing in the year 2000. You'll see they're now 34 years old, this group, 70 individuals. There were 46 taking antipsychotics and 24 who were off. Think about this. This is just a snapshot, okay? You take 70 people diagnosed with schizophrenia, born in 1966, you look at how they're doing in 2000, and then you look at whether they've been medication users or not, okay? And here's their outcomes. You'll see that the group off is 3 times more likely to be in remission. And again, look at the group on meds. A lot of, it's only 20% remission. I'm never going to convert slides to PowerPoint again. This second one is like an employment one. Third one is married cohabit, whether they're in a relationship. You'll see the off antipsychotic group is better in every way. The last one is a disability number. In other words, the group on antipsychotics is much more likely to be disabled. Okay. 5 minutes and I'm almost done. How about that? Really, the question here today is there evidence that we can review? And what does it add up to? And there are going to be all sorts of interpretations. No question about it. But in my view, as you try to assess this, we're talking about the long-term evidence. The drug withdrawal studies are what are cited. But now look at how the literature starts adding up on the other side. We have that retrospective study. We have Rappaport's 3-year study. That's the 1970. We have Mosher's Soterio study. And then we have a biological explanation for why you get higher relapse rate with conventional care. Then we have a cross-cultural study. Then we have an MRI studies. We have a longitudinal study. We have a randomized study, medication compliance, an early episode study, a birth cohort study. The question is, does that body of research over time, what do you draw from it? Okay? What message do you draw for it as you try to develop protocols to help people have good long-term functional outcomes? You'll just see this. This is an editorial that appeared in the British Journal of Psychiatry. It's time to appraise whether we should be using these antipsychotics. And I love this line. This is not a wild cry from the distant outback, but a considered opinion by influential researchers. In other words, it's not just crazy people like Whitaker saying this, but there's some respected researchers saying this. And I love this British line. There is an increasing body of evidence that the adverse effects of treatment are, quote, to put it simply, not worth the candle. It's a great British call. Now, the beauty of this story is that there has been a group, in my opinion, that has since 1992 been using antipsychotics in a selective use model that is consistent with what I think this research is showing. And what I think this research is showing is that with your first episode patients, you should try to see, with intensive psychosocial care, who can get through that episode without going on drug and not have this dopamine supersensitivity. And that's going to be a segment of your population, and that one's probably going to have the best long-term outcomes. Who needs it short-term, and then who needs it long-term, okay? They've been doing that since 1992, and it's really, here's their antipsychotic use. They do not put people on antipsychotics right away. They do use benzos to restore sleep-wake. It's not an anti-med thing. But if someone is not getting better after 2 weeks, 3 weeks, and they have a scale called a grip on life, if they're not bathing, showering, willing to come into things. If they're not improving, now they use low doses of antipsychotics. And then in that group that goes on antipsychotics, 6 months later they see who can come off, okay? That's the protocol. And you know what they say about that initial treatment with not antipsychotics? You have to tolerate uncertainty. You don't know which group is going to get through it, okay? So, here's their outcomes. At the end of 5 years, 67% of their first episode patients have never been put on antipsychotics. I want to emphasize one thing. The psychosocial care, the open dialogue therapy, you've heard of open dialogue, is intense. They're throwing a lot of resources into helping people in their isolation be able to reintegrate into society, okay? So, 67% have never used them, 13% have used them only temporarily, and 20% now are using them chronically, okay? And what are their outcomes at the end of 5 years? 80% are asymptomatic, and either 80% are working or in school, and only 20% on disability. One of the most remarkable things here, if you look at that group that's in the job market, basically 80%, they have a lower unemployment rate than a matched cohort for age in the general population. That's how good they are getting people back to work, okay? So, open dialogue is now being exported and tried in other countries, but it's not necessarily being married with the selective use protocol. So is that an important part of open dialogue or not? You have to ask yourself this. Here's what the leading researcher says. There are patients who may be, I'm confident of this idea that it is important. There are patients who may be living in a quite peculiar way, and they may have psychotic ideas, but they can still hang on to an active life. But if they are medicated because of the sedative action of the drugs, they lose this grip on life, and that is so important. They become passive, and they no longer take care of themselves. So that's a question for you in terms of how you deal with your psychotic patients. Is there some benefit to not having this done? By the way, there's a comparison of a similar type of care in Sweden where they use medications regularly, and compared to the northern Finland. This happens in an area of Finland called Western Lapland. It's in Tornio. It's in the north of Finland. It's a population of about 70,000. They did a comparison study with Sweden, but where they used antipsychotics regularly, and Sweden did not have the same good outcomes. And that apparently is it. So last word here. I think this sort of day could not be more helpful. You should hear different of opinions. You should hear what some of the issues are. You saw that we agreed on some of the issues. Is dopamine supersensitivity a concern? Is brain shrinkage a concern? And then you can look at this, and you can look at the outcomes, and then you can start to have discussions about what is possible. One issue to me is, should you set up a program with first episode patients where you do not immediately put everybody on antipsychotics? I'm of the opinion you should. Others are not. But I think it's a valid question. And then the question is, should the goal be, long-term, to have medication adherence for as many people as possible, which is generally the thought, or should you, in fact, try to minimize long-term use? And then the final question for you all here is this. What is the natural recovery from psychotic episodes, first episode? Because one of the thoughts is, in the conventional view, it's only like 15 to 20%. I'm of the view it's much higher when we're talking about first episode psychosis. I'm getting hooked. You see the hook? Anyway, I hope to leave you with questions. Thank you very much.